So I feel like I'm sort of going to be the bubble burster here, because we've already talked about lots of options available to people, but when you get to dementia, things get a little different. So just bear with me. Don't throw too many tomatoes. Let me just, I know many of you already know this, but just to make sure we're all on the same page, okay? So dementia, what is it? Disorder with decline in mental abilities severe enough to interfere with daily life. That comes from the Alzheimer's Association. You can just Google it and find it. There are different types of dementia out there. There is Alzheimer's, which is probably the most prevalent type of dementia, but there are others. So vascular dementia, that comes from multiple strokes, so that people with vascular dementia just sort of have slower downward spiral as each stroke takes hold. Then there's Lewy body dementia, which looks kind of like Parkinson's disease. And then there's frontotemporal dementia, which often shows up earlier, sort of middle age, and can manifest with more personality changes than memory problems initially. All dementias are progressive and ultimately terminal. Often people will think, oh, somebody has Alzheimer's, and don't realize that that is something that eventually is going to kill them. And the rate of progression of dementias varies. So some people live with dementia for a few years. Some people live for 15, 20 years. And there's no way to know at the onset what your trajectory is going to look like. Okay. Oh, good. You're way ahead of me. Excellent. So just to give you guys a sense of the different stages that people go through with dementia. So stage 1, I guess that's me. I appear normal, and I'm pretty good at covering up lapses, right? Maybe some of you too. Stage 2, you forget certain things, but otherwise function fairly normally. Actually, maybe I'm stage 2. Stage 3, difficulties at work. People start becoming sort of anxious because they realize something isn't quite right. Family becomes aware that the person is maybe not quite doing what they used to be able to do. Stage 4, there's a reduced ability to be able to count. Traveling is difficult just because of all the things you have to think about to pull off getting from point A to point B. You no longer can manage your own affairs. So other people may be doing your bills, other people may be doing your cooking, that kind of stuff. Stage 5, you now are having trouble with what we call activities of daily living, so getting yourself dressed, remembering that it's winter and we don't wear shorts and t-shirts unless we're in middle school, right? Stage 6, people at that point are going to need help eating. They'll need to be fed probably, need help using the toilet. They may be incontinent. They often won't know where they are, what time of year, what time of day it is. So often day and night get mixed up. People may be up wandering around at night, forget who they are. And then the last stage, people really are often bedbound. They can only speak a few words a day. They really can't swallow correctly anymore. They're at risk for what we'll talk about in a little bit, aspiration. So you can sort of see the progression of this. I sort of think of it as it's really interesting how there's sort of a parallel process between the beginning of life and the end of life. So little babies are sort of gathering their ADLs, learning to feed themselves and get themselves dressed and then get to school with all their stuff, and then it's sort of, I don't know, I think it's just sort of interesting, sad but interesting. Okay, next. So going into this in a little more detail, this is again from the Alzheimer's Association, which has lots of really good information. So early stage Alzheimer's, a person may notice memory lapses, friends and families may notice difficulties. So difficulty remembering names, words, difficulty planning meals, paying bills, that kind of thing. Okay, next. Middle stage, there's more progressive confusion. Person may wander, get lost, have trouble sleeping. At that stage, people can often get real suspicious because they can't find something. So then they start thinking maybe somebody else stole it. So they can start accusing family members of stealing things, misplacing things, etc. Again, forget about dressing, what to wear. They're not sure what season it is, etc. Okay, next. And then the end stage dementia. I already talked a little bit about this, but you can only communicate maybe a word or two a day. You need help with your activities of daily living. You're incontinent of bowel and bladder. You have trouble swallowing. And there's lots of literature now in the medical literature that putting feeding tubes in people with advanced dementia does not improve things. I'll get to this a little more. I think that literature's been out for a while, but it still hasn't been adopted widely. And in nursing homes, it's much easier to feed someone with a tube than for some poor staff member to sit there for an hour trying to feed somebody. So there's sort of incentive to put feeding tubes. Nursing homes will get paid more money if they have somebody with a feeding tube versus somebody with hand feeding. So at this stage, you can't walk unassisted. You may not even be able to sit up. And so the implications of this, which I sort of alluded to, are people can choke on food, or they can aspirate, meaning the food can end up in their lungs. Lungs don't like having food in them. You can get pneumonias, etc. And then because you're not moving around, you're lying in bed, and your nutritional status isn't very good, you're at risk of getting bed sores. Okay, so the infections are often what people with end-stage dementia die of. Okay, so Bree already showed this, but I got it too. Just to remind you that with different diseases, people's end of life can be different. So the top line there is cancer. People with cancer can sort of perk along and do fairly well until the end when there's a sharp drop-off. The middle line there, the red line, is sort of chronic illnesses. So like COPD, which is emphysema, heart failure, kidney failure, those kinds of things. People can have a slower decline, but there are these periodic exacerbations where they get worse. They may get a little better after they get treated, but they don't go back to where they were before that exacerbation, okay? And then the last line, which Bree already talked about as well, that's kind of like dementia in the dwindles, where you sort of just perk along, not real functional for quite a while. Okay? All right. So talking about end-of-life options for people who don't have dementia, and we've already talked about a lot of this stuff today, but just bear with me. So you can continue with active disease management, right? You can take your medications, you can go to the doctor's appointments, you can go to the hospital when you get sick, you can get tests and labs and all of that stuff. And after you go to the hospital and you're deconditioned, you can go to a nursing home for a subacute rehab stay to get physical therapy, occupational therapy, get strong enough to go back home. So that's sort of the usual thing that happens to people. When people are terminally ill, they can qualify for hospice care. With hospice, you have to have a 6-month prognosis, which can be hard for us to estimate. We're notoriously bad at knowing, so there are people who I say, oh yeah, they've got a 6-month prognosis and they live for, a couple years. There are other people I say, no, they don't have a 6-month prognosis and they die the next day. That happens. We don't have a crystal ball. We get it wrong. But to be eligible for hospice, a doctor has to say you have a 6-month prognosis if your disease runs its normal course. You have to elect for comfort-focused care. You get a 24/7 nurse access. The nurse doesn't move in with you, but they are available by phone should there be some crisis in the middle of the night, so that can really be helpful to family members. And I have there that, the care comes to you, so the nurse will come to wherever you are and check on you, but they come maybe once or twice a week. They don't move in with you. as much as we would like that. And then another option, which Bree already talked about, is stopping life-sustaining treatments, right? So I don't know if you guys can see the slides way at the bottom, but if you have cancer, you may elect to stop chemotherapy. If you're on dialysis, you may decide you want to stop that. She talked a little bit about stopping medications and other things. Next slide. So more options if you don't have dementia, right? We've talked a fair amount about death with dignity, right? You have to be a Washington State resident. You have to have a terminal prognosis. You have to have what we call decisional capacity, meaning you have to be in your right mind to be able to make that request. You have to make 2 oral and 1 written request. You then get the lethal medications that you have to take on your own. And we already talked about the fact that it's expensive, right? And then there's this other option of voluntary cessation or stopping of eating and drinking, right? And that can get tricky as well. It's much easier to pull that off if you have decisional capacity when you start it, okay? It also helps if you have good family support, because as we already heard, as people go through that process and their bodies get more dehydrated and they get confused, they may forget why they decided to do this in the first place, and they may be real thirsty, and they may start saying to their family members, "I'm really thirsty, can I have some water?" And that can be really tough on the family members. Do they have to spend their time continually reminding the person, remember what we're doing? This is why we're not giving you any water. And if the person's in a facility, that gets even harder because the paid caregivers may not be at all comfortable with doing this. This, for them, may feel morally wrong. And we don't want people to do or not do things that they feel is, big capital letters, wrong. Okay, next. So now what about the options for dementia, sort of to contrast with what we just talked about? So there is continuing usual care, right? You can have dementia, but you can keep taking your medications, you can keep going to the doctor's appointments, you can go to the hospital when you get that pneumonia, etc. Just like anybody without dementia, you may need to go to a nursing home for rehab, because people with dementia who've been in the hospital can get deconditioned too and may benefit from rehab to get a little stronger. Sometimes they can't though, because they don't remember the exercises from day to day. So they don't really benefit from that. So they may end up being in a facility for long-term care if their family can't take care of them, if they can't be in an assisted living, if they can't be in an adult family home, whatever the reason. We talked a little bit about hospice being an option. Now with dementia, if you're going to be on hospice for dementia, it gets really tricky, because the criteria that I will look at to certify that someone is hospice eligible for dementia, they have to be really far along. They have to be bed-bound for the most part, not talking, incontinent of bowel and bladder, etc. And even if they meet all those criteria and we sign them up for hospice, some of those people may live for a few more years in that state, okay? Then there's death with dignity, but unfortunately, the law says that you have to be terminally ill. And when you're terminally ill with dementia, you no longer have decisional capacity. You aren't in your right mind. You can't make, you could request something, but you don't understand really what it is anymore. So if you hit the next thing. You're not going to talk about the last one? No, good, you hit the thing. See, then we get a little X. Isn't that cool? Sorry, I'm sort of low tech, so I think these things are fun. Okay, then there's voluntary cessation of eating and drinking, which is going to be tricky in dementia as well. So earlier in dementia, you may have decisional capacity, you may be able to make this choice, but then in a way, you're ending your life prematurely, and perhaps as your dementia progressed, maybe you would have had some good times. There are some people who have no clue who they are or where they are, but they're actually quite happy. And so that can get really hard too. If you have in a directive You know, if I get like this, I don't want to keep going. And now you're sort of a new person, and you're just as happy as a clam, sitting there sort of watching people go by, maybe watching birds or whatever. To you now, that may sound like, oh, you know, I wouldn't want to be kept alive for a minute like that. But what happens to your family when they see you later on like this? And you look very content and peaceful and happy. Do they go with the then self or the now self? That gets really tricky. So yeah, if you make the decision later, the family has to sort of honor it for you. Legally, it gets a little tricky though, because you don't have capacity. And what if you have a directive that's written? The directive has to be really specific. You know, when I get to be like this. But I think even then, I think we have a lawyer, right? Are you going to talk about this? Okay, good. I'm gonna let her do that. Okay, next. Oh, and then the institutions. Yeah, that gets really tricky again, because of the people who signed up to work at those places. They signed up to work at those places to sort of help promote health, not to help people off themselves. Okay. So more end-of-life options in dementia. So you can refuse things, and we've talked a little bit about that, right? So if someone wants to put a feeding tube in you, hopefully your family will say absolutely not. That will not change anything. That will only make this person more miserable. If you're in an institution or an adult family home, assisted living, you can sometimes have what they call a do not hospitalize order. Meaning you're there, you develop a pneumonia, they will not ship you off to the hospital. And then Bree talked a bit about POLST forms, and they can be really helpful too. They can sort of help promote what you want. And if you're in that nursing home, or if you're home and something happens and some neighbor is there and they freak out and they call 911 and the paramedics come, if they see this, they will honor it. In the olden days, if the paramedics came, they would ship you back to the hospital. Nowadays, the paramedics see your POLST form on the fridge, they will honor it. So if you're in cardiopulmonary arrest, they will let you be in cardiopulmonary arrest. They won't try to bring you back, okay? So you guys may already know this, but just so that we're all on the same page, there are 4 parts of the POLST form. The first part is about what they call code status, meaning do you want to be resuscitated or do not resuscitate, DNR. What's your wish there? The second option, the second section has to do with sort of overall focus of care, and there are basically 3 options. So Bree talked about comfort, so we're going to do everything we can to make you comfortable. Some interventions, what they call limited additional interventions, meaning maybe we would go to the hospital and we would treat you with some antibiotics if you were, had a pneumonia and you were really short of breath. And then the last one is all life-prolonging interventions. So you are okay going to the hospital, you're okay being in the intensive care unit, you're okay being on a breathing machine. All of that sort of really fancy stuff we can do to people. And I think a point to make too that I don't think is anybody in this audience, but there are some people, there is a segment of the population that actually wants to go out fighting. And I think, at least in healthcare, none of us want that. And it can be really hard for us when we're taking care of somebody who has such different preferences. But when somebody wants to go out fighting, then maybe it is reasonable for them to try to be resuscitated and to be in the ICU and to have all this stuff being done to them. Okay. Okay, next section is use of antibiotics. And this one, I think, gets really tricky. So you can have antibiotics to prolong life. Okay. You can have antibiotics for comfort, or you can say do not use antibiotics. I'm going to talk a little bit more about this one in the next slide. And then the last section is on feeding tubes. Okay, so a little more thinking about this in terms of dementia. So if you've got dementia and you get resuscitated and you actually survive, then your chances of your cognition being what it was before you were resuscitated is about 0. So you may be alive, but your cognitive abilities are going to be even worse than they were before that. Overall focus, again, if you don't just pick comfort, then you will have stuff done to you, and we're pretty good at doing things to people to keep them alive, okay? Antibiotics, I can't tell you how many people check off antibiotics for comfort, because that sounds really nice. The problem is with dementia, what are the things people die from? They die from pneumonias, they die from urinary tract infections, they die from wounds. And so if we do antibiotics for comfort, we're actually keeping you alive longer. Okay? So I can't tell you how many people I've sort of said, yeah, it sounds really nice, but this is what it really means. Plus, there was this fancy research study that came out in 2010 where they looked at people with advanced dementia who'd gotten antibiotics for pneumonia. And they found that sure enough, these people lived longer, but it didn't make them more comfortable at all. So in a way, it's not even really true that we do antibiotics for comfort. Okay. Yeah, and we can do other stuff for comfort. Okay, now the feeding tube thing. I already sort of alluded to this. There's now lots of research out there that putting feeding tubes in people with advanced dementia doesn't make you live longer, doesn't improve your quality of life, doesn't prevent pressure sores. People sometimes need to be tied down so they don't pull them out. I mean, it's bad, okay? And so the American Geriatric Society and the American Academy of Hospice and Palliative Medicine both came out with sort of things that patients and their physicians should talk about. Each society, you know, all kinds of medical societies had to pick 5 things that they thought were a big deal through this, what they call the Choosing Wisely campaign. So you can Google Choosing Wisely, you can pick which medical society you want, and you can look at what 5 things they picked. So both the American Geriatric Society and the Hospice and Palliative Medicine group both picked think before you put in a feeding tube. Okay? Next. So other things to think about, since the options with dementia are more limited than with other illnesses. It is super important that you designate someone as your durable power of attorney for healthcare. People with mild dementia may not be able to make sort of more complex medical decisions, like whether they want chemo or not, but they may still be able to designate someone. If I get really sick, yeah, I want him to make decisions for me. Okay? And then it's really important to communicate your preferences to your loved ones, right? I can't tell you how many times I've been in the hospital with patients, they're in really bad shape, family comes in, family has no idea what they want. And that can cause so much distress for the family members. So things to think about, because we don't really, for the most part, we may not know what fancy procedures and treatments we want or not want. So think of it in terms of these other questions. So what makes life worth living for you? When does life cease to be worth living? So with dementia, is it when you can't recognize your family? Is it when you can't swallow on your own anymore? Or maybe if you're still happy as a clam watching the birds, maybe it is still worth living, okay? Yeah, but appear happy. So if you can communicate, if you can figure that out, because this stuff is really hard to know, but if you have a sense of what it means for you and can communicate that to your loved ones, that can be a huge help, both to them and for you to get what you want, okay? And then there are these advanced directives that are dementia specific. So our friends here from End of Life Washington have a really good one. It's really long, but it's pretty specific. And I brought one if anyone wants to look at it. You can just find it online. The other one I brought, so I'm from the VA, you know, but the VA has a really good one, I think, because it has all these awful situations. You know, and would you want life-sustaining treatment in that awful situation or not? So I brought that too. You can also just Google VA Advanced Directive and get to it. The other wonderful thing about the VA one, I think, is it has this section Section D, how strictly you want your preferences followed. Which is really good, because I can't tell you how many times patients in really bad shape, family members there, family members saying stuff that doesn't seem to fit with what the patient wanted. But if the patient checked off, I want my preferences followed generally, then it's okay that the person is doing something different. And there are plenty of cases where the patient may say, this is what I want, but if she needs to keep me alive a little longer so that she can get on with her life, I'm okay with that. Okay, that's sort of what it's getting at. Okay, what else we got? Oh, that's it. Okay, so, do we have time for questions or did I go too long?
No, we have
Okay, time for questions.
Oh, Lisa did a great job.
Thank you.
So let's thank Lisa. There's a question over here, and I'm going to take the time to repeat the question.
Okay, good.
So my husband already has dementia, and I'm his power of attorney, and can I sign,
A post?
our advance directive?
You cannot sign an advance directive, but you can sign a post.
So for those of you in the audience who don't know what POST means, it's the physician orders for life-sustaining treatment. That's where the word POST comes from.
It is that bright green.
It actually has a longer name, but we end up calling it POST. This is the thing that many times gets posted on your refrigerator. So, and that's, the EMT is likely to look for it there, as that's the most common place where we stick those when you are in a serious enough illness that you're wanting to make sure that those wishes are followed if 911 gets called. We have a question here.
If you have on your refrigerator, do not resuscitate, and you fall, and somebody calls in the medics, do they look at that? I've been told two different things about that.
So the question is, if the post is on your refrigerator with a do not resuscitate, will they honor it?
Okay, so you fell, so now I'm going to be all nerdy and doctory on you. Do you have a pulse and are you breathing? Because if you have a pulse and you're breathing, but you're not conscious, you don't need CPR. CPR, cardiopulmonary resuscitation, is when you're dead. So you're not breathing, your heart isn't beating anymore. But if you fell, maybe you bonked your head and you bled in your head a little, and it gets really tricky. So
what do they do?
So then it looks at the second part. So they've checked and they make sure that you got a pulse and you're breathing, so you don't need to be resuscitated, but they can't wake you up, okay? Then they'll look at the second section. So does it say comfort measures only, in which case they probably are not going to ship you off to the hospital? Or does it say one of the other two, in which case they may decide that you need to go to the hospital for an evaluation?
But if you have a healthcare directive already on file that says you do not want to be resuscitated, do they have any way of communicating through the?
So the post, if you're dead, right?
Yeah.
Okay.
So if you need to be resuscitated, you are dead.
Yeah.
You're coming back from not being able to breathe and having no heartbeat. That's what the word resuscitation means. And I think that, but so.
Sorry, I didn't explain that. I'm sorry. Yeah.
Did that answer your question?
And usually what happens too, the post is supposed to be portable. So when it was developed in Oregon, it was initially developed for folks in nursing homes so that when they went to the hospital, the form went with them to indicate to the hospital what the person wanted or didn't want. So it's supposed to sort of go with people, although sometimes that doesn't happen.
I'm going to come back to you, Terry, but just I want to say for those of you here in Whatcom County that one of the common things we hear from people when we ask them if they have an advanced care directive or a post is, oh yeah, I've got it, it's in my safety deposit box. It does no good there. You need to make sure that if you have an advanced directive that it is that your durable power of attorney for healthcare has a copy of it, and that it is on file at St. Joseph's Hospital, because in Whatcom County that's where you're going to get taken if you actually get taken to the hospital. And at St. Joseph's, there's a tab on the entry page at St. Joe's that says Advanced Care Directive now. And so we are working with the hospital to make sure that when someone gets admitted, that we know whether or not they have an advanced directive. Terry, you had something to add.
Make a copy and take it with you on vacations.
Yes. Make a copy and take it with you on vacation.
Put one in your car.
Yes, have a wallet card. The Whatcom Alliance for Health Advancement has wallet cards that say I have an advance directive on file. So the more people who know that you have one and where it is and what it says, the more often you have these conversations with the people you love and care about, because your choices may change over time. I mean, if I write my first advance directive at 18, when I get a driver's license, which is when I think everybody should write their first advance directive, the choices about what I think are a quality life may be quite different than the ones I make at 70, or at 80, or at 95. Because our preferences change, our ideas about what we can do. I mean, I used to think if I couldn't hike to the top of Mount Rainier, I didn't want to be alive. Well, I don't hike to the top of Mount Rainier, let me tell you. So those things change.
Yep.
Yes?
Does the EMT who home or somebody else in an automobile accident, do they have access to the records in the hospital where they can determine?
On site? I don't think so.
They don't.
Why not? It would seem to be
Yeah.
in this day and age.
Wouldn't that be nice? So in Oregon, they actually have, for the whole state, they've got sort of a pulse database that people can access. Yeah, that would be swell. We should work on that.
Bonnie?
So I work in home health, and my understanding is when the EMTs come out and they look at your pulse, they see what doctor
Signed it.
has signed it, and then there's the team working with you and on whatever you're being done, and then they have someone on the team that's calling the on-call doctor to
Right.
say,
So they make an
"This
effort to call.
This is what's happening."
So when an EMT comes, they make an effort to call the person who signed the pulse form if they
The
can.
on-call doctor for that. That's my understanding.
Yes?
I have a pulse, but my doctor that has signed it is going to leave the community. Do I need to have?
Okay, so the question is, I have a pulse, the doctor who signed it is leaving the community, do I need to get a new one signed?
It's still valid, but when you meet a new doctor, it might be perfect to take your old one and say, hey, let's do a new one.
So we did a screening the other day of the Being Mortal frontline program with it, and those of you who have not read Atul Gawande's Being Mortal, it's an excellent book about some of these same questions. And it was interesting because in the feedback we got from the audience, over 50% of the people in the audience had an advance directive and had it filed, but only 14% had had a conversation with their physician about it. And so it's important that you actually take that next step and also have the conversation not only with the people you love, but with the people who are providing you health care, so that they are very clear about what your choices are as well. Okay, thank you so much.